Hello everyone. Today's topic is septic shock. Myself Riza Sadakat, and I have a bachelor's in dentistry and a master's in public health, and I have an experience of working with MyAussieTutor since the past 1.5 years, and I have been associated with academic writing since the past 1.5 years as well. So let's begin. Today's topic is septic shock. It is a very common nursing topic. It is usually comes in questions and in various uh, assignments for nurses and medical students as well. So let's start. Yeah, so first of all, what is shock? Shock is a clinical manifestation failure of cellular function due to inadequate tissue perfusion and resultant cellular hypoxia due to a reduction in the effective circulating volume of blood in the body. Shock is classified basically on the initiating mechanism in the following ways. That is a hypovolemic shock, where there is effective reduction in the circulating blood volume. Cardiogenic shock, where there is a failure of the working of the cardiac pump, that is the heart. Distributive shock, where there is vasodilation and peripheral pooling of the blood, which could either be septic, anaphylactic, or neurogenic. And in our case, it is the septic shock that we're going to discuss in our presentation today. Septic shock results from moderate to severe sepsis, whereby tissue damage occurs as well. It is considered as a part of a spectrum and a progression of a systematic inflammatory response syndrome. Further definitions that we need to understand to get an idea about septic shock clearly is bacteremia, which is transient invasion of bacteria in the blood circulation. Septicemia, prolonged bacterial presence in the blood associated with systemic reaction in the body. SIRS, that is systemic inflammatory response syndrome, which is characterized by the presence of core temperature greater than 38 or less than 36 degrees Celsius, and heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, and WBC count either greater than 12,000 cells per ml or less than 4,000 cells per ml. Moving on, sepsis is defined as a systematic inflammatory response syndrome with a clearly established foci of infection. Severe sepsis is related to organ dysfunction and hypoperfusion. After your established focus of infection has been established, there is organ dysfunction due to hypoperfusion, that is less perfusion of oxygen to the organs, because of which they stop working, and that leads to a condition known as organ dysfunction. Septic shock is a condition which is severe sepsis, which is not responsive to IV infusion of fluids for resuscitation and needs inotropic and vasopressor agents to maintain systolic blood pressure in the body. A situation where the sepsis transforms into septic shock is where the sepsis has reached the severity level, highest severity level, and it is not responsive to either IV infusion of fluids for resuscitation and needs inotropic and vasopressor agents to maintain systolic blood pressure. Moving on, etiology and risk factors. First of all, the sources of infection could either be endogenous or exogenous. Endogenous sources of infection could be skin, urinary tract infections, lower respiratory tract infection, GI infection, bowel surgeries, perforations, etc. And exogenous sources of infection could be surgical instruments, machines, drapes, imaging machines, healthcare staff, infection that is carried by healthcare staff, etc. Not maintaining proper sterilization protocol, post-surgical, before surgery or during surgery. Everything could be a source of infection for the patient, which could lead to the bacterial invasion in the body and further lead to the stages of sepsis and septic shock. Sources of infection. Now, first of all, the causes of infection could be gram-negative and gram-positive bacteria. Most commonly occurring septic shock cases and sepsis cases are those from gram-negative bacteria, where the most common cause is E. coli, followed by Klebsiella, Enterobacter, Serratia, Proteus, Pseudomonas, and bacterioids. Gram-positive bacteria are also responsible for 1/3 cases of sepsis and septic shock, which include Streptococci, Staph, Clostridium, and Pneumococcus. Viruses, parasites, and fungi can also become potential sources of infection and septic shock in immunocompromised individuals and immunocompromised patients. Now, there are certain risk factors. Even though this bacterial invasion has occurs in some people, it does not lead to sepsis or septic shock, because there are certain risk factors associated with the development of sepsis and septic shock, which can lead to the development of sepsis and septic shock in patients where even a mild bacterial invasion or a fungal infection can lead to this condition, the development of this condition. And these risk factors help in exacerbating the situation, which include age. Higher the age, if the patient individual is towards the higher end of the age, then higher risk for development of sepsis or septic shock with any mild bacterial infection. Malnutrition, also another cause that leads to the development of sepsis and septic shock. Anemia, primary disease, could be anything related to infection, bacterial tuberculosis, any bacterial infection that can lead to bacterial invasion. Immunosuppression, immunocompromised individuals again are at a greater chance of developing infection, which can then further lead to bacteremia and sepsis because the body is not able to fight infection appropriately. Necrotic tissue, poor surgical intervention, where the surgical intervention has not been carried out appropriately, and there is an issue of hygiene, proper maintenance of surgical hygiene, and also maintenance of appropriate uh, surgical protocol. Prolonged hospitalization, where you are at a greater risk of higher exposure to hospital-acquired infections because you are staying in the hospital for a longer time. Major trauma and burns also. Burns are a serious source of infection, especially bacterial infection. Therefore, they can further lead to the development of septic shock in the patient if the burns are of severe category and the infection related to the burns is severe. Moving on, the pathogenesis of septic shock. Infection occurs basically in the body, which leads to the development or the production of microbial toxins by the microbes or the bacteria that enter the body, which help in leading the activation of the host defense system. When the host defense system of the body is activated because of the invasion of the microbial toxins, it leads to an inflammatory response. An adequate inflammatory response will help in controlling the infection. The microbiological toxins are cleared and neutralized, and the patient survives. This is the part of the chart. Moving on to the other side, if the inflammatory response is not adequate, it is inadequate, and the infection is uncontrolled and there is ongoing release of microbial toxins, it leads to an excessive inflammatory response by the host's body or by the patient's body, which leads to tissue injury, which can then cause shock and multi-organ failure, further leading to death. So what is the entire process that goes on, the pathological process that goes on at the molecular level when this infection happens in the body? The microbial toxins are released and they help in activating the inflammatory response, and therefore uncontrolled infection leads to an excessive inflammatory response by the body, causing tissue injury, shock and organ dysfunction, which can further lead to death of the patient. So moving on, it results when infectious microorganisms in the bloodstream induce a profound inflammatory response in the host body, causing hemodynamic compensation. The pathogenesis involves a complex responsive cellular activation that triggers the release of a multitude of pro-inflammatory mediators. This inflammatory response causes activation of leukocytes and endothelial cells, as well as activation of the coagulation system. The excessive inflammatory response that characterizes septic shock is driven primarily by the cytokines tumor necrotic factor alpha A, then TNF alpha, and interleukin 1, which are produced by monocytes in response to an infection in the body. Both these pro-inflammatory and anti-inflammatory responses play a role together in producing septic shock. Septic shock involves widespread inflammatory response that produces a hypermetabolic effect in the body, manifested by increased cellular respiration, protein catabolism, and metabolic acidosis with a compensatory respiratory alkalosis as well. At high levels of LPA that is produced by the bacteria in response, that is produced by the body in response to the bacterial invasion of microbes from the bacteria, the syndrome of septic shock supervenes. The same cytokine and secondary mediators now at higher levels result in systemic vasodilation, hypotension, diminished myocardial contractility, widespread endothelial injury, activation causing systemic leukocyte adhesion, and diffuse alveolar capillary damage in the lungs, and activation of the coagulation system culminating in disseminated intravascular coagulation. This hypoperfusion system that is released in the body is because of high levels of LPS in response to higher attack by the microbial toxin, because body's inflammatory reaction and the body's immune system could not control the toxins initially. The reaction was not adequate enough, so the amount of microbial toxins increases to such a level that the body then excessively responds in its anti-inflammatory response, and that excessive anti-inflammatory response by the body leads to systemic vasodilation, diminished myocardial contractility, and also causes excessive activation of the coagulation system, which further leads to disseminated intravascular coagulation. The hyperperfusion from the combined effects of widespread vasodilation, myocardial pump failure, DIC, multi-organ system failure affects the liver, kidney, central nervous system, among other organ systems as well. This is the entire pathogenesis of how the sepsis converts to septic shock and produces microbial reaction in the body at the molecular level, which the body responds to, and in turn causes injury and development of DIC. Clinical manifestation: now when all of this is happening, hyperperfusion is happening, the body has responded in excessive inflammatory response, which leads to hyperperfusion in the body, reduction in myocardial contractility, increase in breath rate, all of that. So how does it manifest when you look at a patient? What is the clinical manifestation of all the pathogenesis and the pathophysiology that is happening at the bodily level, at the molecular level? So the clinical manifestation that we see, first of all, is tachypnea, that is an increased rate of breathing, which is defined as more than 20 breaths per minute, because there is a lack of oxygen in the body. So the patient will obviously respond by the physiology, it is normal physiology, and the patient will respond by increased rate of breathing. Or when testing blood gas, a PCaO2 less than 32 millimeter Hg, which signifies hyperventilation. Yes. WBC count will either be significantly low because the immune system is completely shut down, or it will be elevated because the immune system is working hyperactively. could be either less than 4,000 cells or greater than 12,000 cells. Tachycardia, rapid heartbeat within sepsis, is defined as a rate greater than 90 beats per minute. Altered body temperature, fever greater than 38 degrees, or hypothermia that is less than 36. It could be anything. Documented evidence of infection may include positive blood culture, signs of pneumonia or chest X-ray, or other radiological lab evidence of infection anywhere in any part of the body, colon, GIT, liver, anywhere. End organ dysfunction are also present in septic shock, including kidney failure, liver dysfunction, changes in mental status, or elevated serum lactate. Treatment primarily consists of the following: giving intravenous fluids, early antibiotic administration, early goal-directed therapy depending on the patient's condition and the stage of sepsis and septic shock that the patient has arrived, rapid source identification and control, whether the source of infection has been identified and the bacteria that is causing the thing has been identified after a culture. So you can specifically give antibiotics to prevent that, and supporting major organ dysfunction. Providing support to prevent major organ dysfunction, and if major organ dysfunction has occurred, then you have to provide support to replace the function of the organs that have dysfunctioned. Thank you so much. So I hope you have basically understood what is the pathogenesis of septic shock, what happens in the body in response to a bacterial invasion, and how it leads to development of sepsis and septic shock, and how it eventually leads to the death of the patient, causing multi-organ failure and death, and also what can we do at a nursing level to manage the situation, and what is the methodology that can be applied to manage it, and how it can lead to making sure that the patient survives. And what is the procedure or the protocol that needs to be followed in cases such as this, when the patient comes to the hospital in this particular condition? What are the clinical signs to look at in the patient to make a diagnosis of sepsis and septic shock? And what are the clinical investigations in terms of WBC count and in terms of blood culture, all of that we have to do, or any radiological or any image investigation that needs to do to look at the foci of infection, in the patient. So I hope all of that is clear, and I hope you'll be able to answer all questions related to septic shock, pathogenesis, clinical manifestation, why they are, and what are the investigations and treatment protocol that we need to follow for any case of septic shock. Hoping to see you again with another topic, another day. Thank you so much.